Thank you. Craig said he'll be here at 10 o'clock, running a little bit late, obviously. And my other two are going to be showing up in a minute. They've got a public works hearing.
Okay. Is there a problem with my starting?
No, you got Mr. Rourke. Go ahead.
Yeah?
Just as soon as I get here, if they can make a
Okay,
mistake.
good. Good morning. The Subcommittee on Human Resources and Intergovernmental Relations, the Government Operations Committee, is now in session. Today, the subcommittee is examining the resurgence of tuberculosis in America as an even more deadly killer than it was in the middle of this century, 30 to 40 years ago. In the 1940s, science gave us the tools to prevent tuberculosis from developing even in infected persons, and also to treat those who have active TB. So why, after decades of control, are we now failing the American public? It is no secret why TB is flourishing. It is for the same reasons that TB raged through our nation decades ago: poverty and its allies, malnutrition, poor health care, and crowded living conditions. That the government would permit TB to reemerge in this day and age is nothing less than an outrage. As we will see today, while TB cases grew in number over the past decade, funds dwindled. The government has had its head in the sand, as it did in the early years of the AIDS epidemic. But there are enormous differences between TB and HIV. First, TB could have been prevented, and it can be cured. But secondly, TB is transmitted through casual contact, and it is spreading to hospital workers, migrant workers, prisoners, prison guards, AIDS patients, school children, workers on cruise ships, and patients waiting in emergency rooms for treatment for other conditions. The tragedy of this epidemic is that we had it under control, but then we dropped the ball. We left the programs that defeated TB run out, unfunded, unattended. We grew to accept a small number of TB cases among poor people, mostly minority. On them, Washington turned its back. TB no longer meant tuberculosis, it meant too bad. The tuberculosis epidemic is a matter of extreme urgency. The cost of finding and treating persons with TB now will be small compared with the cost of our failure to act. When will we learn that we cannot ignore the health of our poor and disenfranchised citizens? The resurgence of TB is an indictment of public health in America, which continues to be crisis-driven. We can put tuberculosis back in the history books where it belongs if we have the will and provide the funds. Our first panel today is composed of experts involved in various aspects of the TB epidemic: an infection control specialist, a researcher, a pediatrician, and a clinician. Then we will hear from 3 experts from the administration who have responsibility for programs, policies, and funds that can be employed for the battle against tuberculosis. We've been joined by our distinguished ranking minority member, Mr. Craig Thomas, and I'm sure that he has an opening statement. Thomas?
Thank you very much, Mr. Chairman. Let me begin by thanking you for holding this hearing today. It's an important problem, of course, for us to address. Tuberculosis was once one of our most feared diseases, in part because it was so easily transmitted. Through education and appropriate preventive steps, it's almost been eradicated and slipped from public view. We now see a return of this disease, a return with a vengeance in some cases. The increase in the number of AIDS cases has been one of the causes. Homeless individuals and the lack of quality care have contributed to its spread. A new multi-drug-resistant strain, which was connected to the death of 13 individuals in New York prison, has caused even more concern. A field hearing by this subcommittee in December dealt with the increase in urban centers. However, in talking to my own state health department in Wyoming, I find that we are not immune in rural areas. Between 1985 and 1990, 5 new cases of tuberculosis were diagnosed each year in Wyoming. For 1991, the preliminary figure stands between 6 and 8. We've also found the first case of multi-drug resistance TB in the state, and regrettably, the possibility of the first AIDS-related case is strong. No disease knows the boundary of urban or rural communities. One of the issues I'd like our witnesses to address today is the one of regression, which may be a problem peculiar to rural states. By regression, I refer to the problem of a lack of doctors adequately versed in this disease. Because its occurrence has been rare, many doctors in rural states have never diagnosed or treated individuals with tuberculosis. This may be one of the causes of the increase nationwide. Questions have also been raised about the lack of a domestic producer of needed drugs. I would like the witnesses from the Food and Drug Administration to address this question. Mr. Chairman, thank you again for holding this hearing, and I look forward to the testimony of the witnesses.
Thank you very much, Mr. Thomas. And our distinguished member from Connecticut, Ms. DeLauro.
Thank you. Thank you, Mr. Chairman. I would like to say thank you to you for calling this hearing on a subject that is of grave concern to the health of people in urban communities across our nation. The new outbreak of tuberculosis, especially the multiple drug-resistant strain of TB, carries with it a familiar fear. This is a fear that many others knew in the years when TB was the leading killer in this country. My mother knew this fear when she was pregnant to me. My father was diagnosed with tuberculosis when my mother found out that she was pregnant and was going to have a child. My father spent a year in the sanitarium and struggling to fight off the disease, and he knew how deadly TB could be because his mother had died in its grip. So when I hear that a new strain has surfaced, as deadly as its predecessors, but with no known cure, I feel caught once again in the shadow of a killer that we thought that we had defeated. The real tragedy of this new epidemic is that it could have been prevented. In the 1980s, it was widely believed that TB had been brought under control. A century ago, TB was the nation's leading killer. Yet just 8 years ago, the United States had achieved the lowest TB rates in our history. As a result, the federal government let down its guard and cut back on the amount of resources it provided for TB services. It is now clear that this was a poor policy based on poor judgment, and it was most likely a deadly decision. The increase in TB cases and the emergence of the drug-resistant strain is not just a matter affecting New York or New Jersey. For public health workers and officials in Connecticut, the task of monitoring TB cases and attempting to prevent the multiple drug-resistant strain from spreading to our state has taken on an unprecedented urgency. There is great fear that the TB epidemic will spread to our urban areas like New Haven and Hartford and Bridgeport. Conditions exist in these cities that would help to spread the disease. Without aggressive outreach services and screening, it would only take one infected individual to set off a nightmare similar to New York's in our state. In Connecticut, we are currently seeing trends that mirror the national findings. During the 1970s, the number of TB cases was decreasing at an annual rate of about 6%. In the 1980s, however, that decline ceased. Now we are seeing between 250 and 300 excess cases a year. TB is rising at an alarming rate in Connecticut's Black and Hispanic communities. Last August, Connecticut became the first and only state in the nation to make exposure to TB when found in conjunction with the HIV virus a reportable disease. This differs from reporting TB when it becomes an active disease, which is a common practice. The link between HIV and TB has been clearly established, with people with AIDS facing 100 times the risk of getting TB. Connecticut has set an example that I believe all states should follow. It's not only possible but likely that the drug-resistant strain of TB will come to Connecticut and to other states as well. That's why we must all work together with the people of New York and other affected areas to help them to contain their TB problems. We must make greater federal resources available to help these communities deal with the enormous problems that they face, because we cannot afford to compound our past mistakes. We should not let history repeat itself, and we should not let TB, our nation's leading killer a century ago, become the epidemic of the 90s. We must take a rational and a humane and cost-effective approach to this problem, and we must provide the resources necessary quickly to stop this epidemic. Again, I want to personally thank you, Mr. Chairman, for calling this hearing this morning.
Thank you very much. Thank you very much, Mr. Lauro. And now let me invite the participants in our first panel to step forward. And before you sit down, stand behind the chairs where your nameplates are designated. Dr. Bloom, Dr. Sauter, Ms. Russell, and Dr. Stark. The practice and policy of the Government Operations Committee is to swear all witnesses in. And so if you raise your right hand, do you swear or affirm that the testimony you're about to give will be the truth, the whole truth, and nothing but the truth? Thank you very much. Let the record indicate that each of the witnesses has responded in the affirmative. Dr. Bloom, we have you listed first, so if you'll pull that microphone close to you and proceed, give us just a brief indication of your biography and your background, please.
Mr. Chairman, distinguished ladies and gentlemen of the committee, I'm Barry Bloom. I'm an investigator for the Howard Hughes Institute for Medical Research, professor at the Albert Einstein College of Medicine in New York City, and chairman of the Immunology of Tuberculosis Committee of the World Health Organization. I would like to begin by reminding you that infectious diseases remain the largest cause of death in the world. Tuberculosis represents the single largest cause of death from any infectious disease. That means in the world there are 8 million new cases and 3 million deaths from tuberculosis. This is not a disease that has gone away. It represents about 18% of adult mortality in developing countries. People are perishing not only in the third world, they're perishing in the United States as well. As you mentioned, after a 70-year decline, we now have a rise in, since 86 to 90, in excess of about 28,000 cases, and that number is increasing. We know the reasons. They're not hard to discern. The disintegration of the social structure in many of the cities in the United States, the inflammation of AIDS pouring oil onto a burning fire, and the decline and fall of a public health infrastructure. The ominous consequence is the development of drug-resistant strains for which, in many cases, we now have no available drugs. In New York City, 1 out of 3 isolates of tubercle bacilli are resistant to 1 or more drugs. And this is a consequence of a failure simply enough to maintain treatment for the appropriate period of time with drugs that have traditionally been very good. It is shocking that in Tanzania, Malawi, Mozambique, and Nicaragua, 80% of people are cured of tuberculosis, whereas in at least one hospital in New York City, the cure rate is about 11%. We know a certain amount about tuberculosis. We know that 1 infectious case can transmit infection to 10 to 12 people, and that each infected person has a 10% lifetime chance of developing tuberculosis. We also know that each HIV-positive individual has a 80% annual risk of developing tuberculosis. And consequently, what we know is this epidemic has set back by a generation our ability to eliminate tuberculosis in this country. I'm a scientist. I concern myself with more what we don't know than what we do know. I have a research agenda. We have no rapid method for diagnosis of tuberculosis. It takes 3 weeks at the earliest and 8 weeks in the most practical case to diagnose whether an organism in a sputum is tuberculosis. And in people who don't have sputa, who have systemic disease, many of whom are AIDS patients, we have no appropriate way to get the bacilli. We don't have a way of discriminating whether those organisms, for another 3 to 8 weeks, are sensitive to any of the existing drugs and what the pattern is. And that means we don't know the risks that our healthcare workers are being exposed to. We don't know very much, if anything, about how the organism causes the disease. We don't know how it gets into the body from the lung. We don't know how it produces disease. We haven't had a new target for a drug against tuberculosis in 20 years, and we have to learn how to work with the pharmaceutical industry to make it of interest to them to begin to learn how to deal with now a whole new ballgame. We didn't think immunity was very important in TB until AIDS came, and we learned that if you lack it, then the rapidity of infection, diagnosis to death, is something the world has really never seen before. We have to learn what that mechanism is and find ways to support it and perhaps make vaccines. We don't know the interactions between AIDS, homelessness, and tuberculosis infection. We don't know where to put our effort most effectively to prevent the disease. We don't know how to treat people who are exposed to multiply drug-resistant tuberculosis that work in hospitals and prisons to protect them from ever getting any infectious breakdown and development of tuberculosis. And we don't know best how to ensure compliance in high-risk groups where if they don't take their drugs, they become a risk to everyone, including themselves. Now, that's an agenda that will not be paid for with the resources that are currently available. If you believe that $5 million with an increment of about $200,000 will address some of the scientific questions on drug development and diagnosis, I would have to hopefully graciously disagree. If you believe that the money available through CDC to the states, which is less than half of what New York City has requested to deal with the problem in New York City, will adequately address the problem of tuberculosis, I must respectfully disagree as well. And if you realize that the Center for Analysis of the Data in the country, the operations program at CDC, has had no increase in budget for 4 years in the midst of an epidemic, it's not likely that we will have faster, more accurate, and more up-to-date information and communication than we have at the moment. This is not a problem that will be solved with one-year emergency funds, but whatever the investment is, as Mr. Weiss has said, the prevention of this disease is much cheaper than catching up when it is out of control. The drugs for TB cost about $275 to treat an ordinary conventional case and about $6,000 to treat a multiply drug-resistant case. It costs between $100,000 and $200,000 to treat every multiply drug-resistant case. We simply can't afford to allow it to get out of control. Mr. Chairman, we have tuberculosis in all 50 states. We have drug resistance in 36 of those states. We know how to treat and prevent conventional tuberculosis. We're not doing it. We must learn how to address and prevent the problem of multiple drug resistance. I'm not asking for an army of scientists to make a war on tuberculosis. I'm asking for a realistic and sustained commitment to the public health in this country and protecting it against a killer disease. Thank you, Mr. Chairman.
Thank you very much. And now we'll hear from Dr. Sauter, Dr. L. Sauter.
Good morning. Thank you, Mr. Chairman and distinguished members of the subcommittee for allowing me to testify this morning. I'm Wafa El Sadr. I'm the Director of Infectious Diseases at Harlem Hospital and also the Director of the HIV/AIDS program. Tuberculosis, a disease long thought of as confined to the developing world, is today resurgent in the cities of America. A three-pronged effort is necessary to contain the epidemic. First, a research program that can advance our basic understanding of the disease. Second, attention to the essential support services necessary to make TB control programs effective. Third, special attention to the prevention of TB transmission to those in close contacts with patients. I address you today as a healthcare worker at Harlem Hospital, a facility located in the community with the highest rate of tuberculosis in this country. My message is urgent. We must develop and fund programs that can stop this epidemic in its tracks. How can the TB epidemic be stopped? I believe through knowledge, effective treatment, and prevention. Let me address the issue of knowledge first. The archaic state of knowledge regarding tuberculosis. It was widely accepted that the disease had disappeared from the United States, and thus research in the area of tuberculosis for all practical purposes came to a halt decades ago. Few efforts were made to develop new methods to diagnose, treat, or prevent tuberculosis. It was thought of as a disease of poor countries or of immigrants. This state of affairs has made tuberculosis an anomaly among medical conditions, a disease of epidemic proportions in the latter part of the 20th century with 19th century technology. It can take months to recognize the infection and to determine which medications to use to treat it. The new face of tuberculosis is the one associated with HIV and AIDS. Many questions remain unanswered in the diagnosis and management of TB in these patients. We still do not know which prevention strategies work best, how long to treat the patients, which combination of medicines are best tolerated, how to recognize the disease, how easily is it transmitted to those with HIV infection, why is the resistant TB organism so deadly for HIV-infected patients. All of these questions must be answered through new research that builds on and expands the AIDS research agenda. Another new factor is the emergence of multi-drug resistant TB, MDR-TB. This form of TB is much more difficult to treat and potentially more deadly. We need to conduct research to quickly identify these organisms, to rapidly intervene and treat the patients effectively, and to prevent transmission to others in the community. In brief, we must catch up quickly. Funding is needed to conduct research on all aspects of the infection, including basic molecular biology, new diagnostic methodology, better drugs, new vaccines, etc. A significant and generous investment in research on tuberculosis must be sustained in order to foster a new cadre of investigators with interest and commitment to this disease. Second, the population at risk. The TB epidemic of today is closely linked to and overlaps to a significant extent with the HIV/AIDS epidemic. It is targeting the same population, the poor, the patients with fragile social support network, and specifically urban African Americans and Latinos in this country. The many patients we diagnose with tuberculosis in Harlem have many concerns apart from their disease. They're poor, they have little support network, they live in a hotel room or in a homeless shelter, they're uninsured or they're on Medicaid. It is not difficult for me, and I think it's not difficult for you, to understand why they have trouble in completing their course of treatment, which often means regularly taking 4, 5, 6 medications for a year or more. It is not simply a matter of prescribing medications and hoping that the patients will take them. New research is needed to understand what works and what doesn't work for our patients, how to simplify the treatment, what combination of medication works best. These research programs and clinical trials must include specific components that make the treatment of our patients possible, including social support services, staffing to provide directly observed or supervised treatment, incentives to continue the treatment, and the cost of the medications. These programs must be linked. There must be linkages between the healthcare facilities and the community-based service organizations. Thirdly, the risk of transmission. The fear of tuberculosis is primarily based on its contagion. With the identification of more and more patients and with the increasing numbers of resistant and difficult to treat cases, there is widespread and justifiable fear of acquiring the infection, especially among healthcare workers. This risk is of concern to healthcare workers, and also these patients are primarily diagnosed and treated by understaffed, underfunded facilities in poor urban communities. I want to paint a picture for you of a crowded clinics where a lot of these patients are being seen by exhausted staff with very few supplies. These are the same facilities and the same providers who've had to deal with the HIV/AIDS epidemic, the resurgence of syphilis and measles. These are also the same facilities that have had difficulty in recruiting and retaining staff. The new TB epidemic means that it becomes all the more difficult to recruit and retain staff under these conditions. How to provide a safe working environment is a critical issue. Many questions remain unanswered. Healthcare workers keep asking for protection, and there are no satisfactory answers. Research needs to be funded to identify and assess methods of protecting healthcare workers and of creating a safe working environment. Methods that we know work must be implemented. However, many of the facilities that need these protective methods do not have the funds to implement them. There simply isn't money to build these protective measures. In conclusion, unfortunately, I feel that the word crisis has been used to describe the state of healthcare for the urban poor of this country too many times. It's been used so frequently that it fails to generate action, yet I feel compelled to use it when speaking of the tuberculosis epidemic. The experience gained in the ongoing battle against the AIDS epidemic is of tremendous value if applied to the TB epidemic. Programs like our program and many others, the Harlem AIDS Treatment Group and other community-based clinical trials programs on AIDS, have been able to do research to provide quality care to patients with attention to their many social needs. Thus, fortunately, the infrastructure and expertise exists to utilize these programs and expand them to fight the new TB epidemic. It is unfortunate that we again have to play catch-up, and again only after disease reaches these epidemic proportions does it require wide attention. Tuberculosis is a contagious disease of risk to all. This means persons of all ages, all races, all economic strata, in all geographic areas, with or without HIV infection. And for that, it must be dealt with urgency. Immediate development of programs and allocation of funds are needed to study and investigate every aspect of this infection if we are to be successful in controlling this epidemic. Thank you.
Thank you very much, Dr. Elsader. Let me indicate, before we go on to our next testimony, that if you would, when you hear the buzzer go off, you try to bring it to a conclusion as quickly as possible. We'll cover the areas, I'm sure, in the course of questioning in any event. And that's not meant specifically to direct at anybody else, but just for our own procedures. Dr. Stark, if we'll hear from you now.
Thank you, Mr. Chairman. Distinguished ladies and gentlemen, I am Jeffrey Stark. I'm a pediatrician on faculty at Baylor College of Medicine in Houston, Texas, and I'm director of the Children's Tuberculosis Clinic of Houston. And I would like to start with a little story. Tommy Carpenter was a beautiful one-year-old boy from Houston who came to my hospital with a severe breathing problem. He had been sick for about 3 months. And although several doctors who saw him thought that he had pneumonia, none did a chest x-ray or a tuberculosis skin test because they didn't think Medicaid in Texas would pay for that. The best friend of Tommy's mother was diagnosed with pulmonary tuberculosis 3 weeks before Tommy was even born. And after a month or two of treatment, she disappeared. And the health department could not find her. It turns out that she was living in Tommy's house. Tommy died 20 hours after admission to the hospital from widespread, treatable, drug-susceptible tuberculosis. This is the new face of tuberculosis in the United States for children. It is a social disease with medical implications. It is no coincidence that tuberculosis case rates in children are rising in an era when measles has again become commonplace, syphilis rates are the highest since World War II, and immunization rates for 2-year-olds in Houston are only 12%. All are symptomatic of a public health crisis for children in the United States. Tuberculosis case rates are rising dramatically among children. For children less than 5 years of age, the incidence has increased 39% in the last 3 years. Between 1985 and 1990, the age group, children or adults, with the largest increase in tuberculosis rate was children, ages 5 to 14 years. Outbreaks of tuberculosis have occurred in daycare centers and schools. In a recent outbreak in a St. Louis elementary school, 38 children developed pulmonary tuberculosis, and almost half the students in the school were infected with the tuberculosis germ. TB in children has several special implications. First, in young children, it often spreads beyond the lungs, causing devastating and permanently crippling diseases such as meningitis and bone infection. Second, every case of childhood tuberculosis, every case, represents a public health failure. Children get TB because the adult they got it from was not diagnosed in a timely fashion, or did not stay on appropriate treatment, or the child became ill before the health department could conduct an investigation. In a study we did in Houston, Texas, 25% of the childhood TB cases could have been prevented if our health department had adequate resources to investigate the adults with TB and their families in a timely fashion. Third, the rate of childhood tuberculosis indicates the current person-to-person transmission of TB within a community. The increasing rates among children mean, by definition, that extensive transmission is occurring now, and that many more children are becoming infected than in the past several decades. These infected children are the tuberculosis cases of the future. Although there is mandatory reporting of tuberculosis disease in children in all states, only 3 states require reporting of a positive TB skin test, which is the hallmark of infection. As a result, no federal agency has monitored tuberculosis infection rates in children in over 20 years, and we have no idea how many children are incubating tuberculosis or where they are. The available data are disturbing. A 1986 survey in Boston Public Schools showed that 5% of 7th graders and 9% of 10th graders had a positive TB skin test. In Los Angeles schools, 3% of U.S.-born students and 21% of foreign-born students test positive. A 1987 survey of 5,000 kindergarten and first grade students in Houston that I conducted showed that 4% of the U.S.-born and 20% of the foreign-born students, 5 and 6-year-olds, had positive tuberculin skin tests, and the overall rate of 5% was 25 times higher than the national average for the same age children in 1971, the last year for which we have national data. Infected students were found among all races, religions, and income levels. The challenges we face for eliminating tuberculosis in our nation's children are enormous, but can and must be met. The absolute key to preventing tuberculosis in children is adequate diagnosis, investigation, and treatment of adults with contagious tuberculosis. Programs utilizing directly observed therapy, where a healthcare worker is present when all doses of medication are taken, must be expanded. The activities of TB control are necessarily labor-intensive. We must make a major investment, and the word is investment, in the infrastructure of tuberculosis control, similar to the investment beginning to take place in childhood vaccine-preventable disease programs. In addition, we must devote some of the money and resources available for tuberculosis to children. There are essentially no funds available for communities to establish tuberculosis screening programs for high-risk children. The federal government currently provides little to no money for research into childhood tuberculosis to develop new and better methods of treatment, diagnosis, and prevention. An effective and safe vaccine against TB will be critical for its control, and the government must safeguard the availability of current drugs and actively promote the development of new anti-tuberculosis drugs that can be used safely in children. The White Plague has returned, and children, as they always do, are paying the price for our indifference and neglect. Unless we address the problem of tuberculosis in children now, this killer disease will be with them for years to come. Thank you.
Thank you very much, Dr. Stark. And now we'll hear from Ms. Russell.
Thank you. Good morning. I am Barbara Russell, Chair of the American Nurse Association's Task Force on AIDS. I am also Director of Infection Control Services at Baptist Hospital in Miami, Florida. Miami has the unfortunate distinction of being among the cities in which the number of recorded cases of tuberculosis is highest. I appreciate the opportunity to testify today representing ANA and its 53 state and territorial nurses associations on behalf of the nation's 2 million nurses. I am also representing the American Association of Critical Care Nurses, the American Association of Nurse Anesthetists, and the Association of Operating Room Nurses. We commend the committee for holding this hearing on a public health problem of grave concern to the nursing community. Evidence that TB is of national concern can be seen on the pages of popular press. A recent cover of Newsweek magazine carries the menacing tones of Little Girl and Poltergeist, marking the return of monsters. We're back. An article in a national tabloid could be a precursor of things to come. The headline reads, TB panic grips Knots Landing. Stars and crew tested for killer disease that can be spread by kissing. Well, Mr. Chairman, Knots Landing today, all my children tomorrow, and we're on the road to public hysteria. Congress must take action to ensure that resources are committed and sound public policy is developed to halt the spread of TB. The administration must exhibit leadership in committing resources to address the prevention, treatment, and research needs evident in the tuberculosis epidemic. Nurses are patient advocates with a long history of providing care and public education in the field of TB. In the 19th century, bedridden TB patients primarily were cared for by general visiting nurses. When it was discovered that poor living conditions were a major cause of the spread, nurses who went into homes to get patients back to dispensaries teach the doctrine of fresh air, good food, and rest. Nurses are still in the front lines, in critical care units, operating rooms, emergency departments, and the community. The sharp increase in the number of TB patients poses a serious threat for healthcare workers who will be exposed to TB more frequently. While a problem in urban and rural areas, the greatest number of cases are concentrated in only a few cities. Nurtured by poverty, homelessness, and drug and alcohol abuse, TB has begun to grip the inner cities. Those with multiple life stresses, poor access to health care, and the burden of poverty are least likely to comply with the medical regime required to completely cure TB. The consequences of partial treatment for TB can be serious, has been already described here. For many years, the method used to ensure compliance with the TB drug regime was for nurses, social workers, or other community workers to go into the community, hand patients their medication, and watch them take it. Directly observed therapy is one of the most effective ways to ensure that a person completes treatment. However, over the years, with decreased funding, such tried and true methods were abandoned. For healthcare workers and patients, drug-resistant TB poses a greater threat in medical facilities with inadequate ventilation and air handling systems. This is especially true for those who are HIV infected, for this population has the greatest risk. The rise in reported TB cases preceded the HIV epidemic and coincided with the drastically decreased funding of TB control and social assistance programs. However, the problems of dually infected individuals and the implications of the TB epidemic for people with HIV infection can be exacerbated by public backlash if they are perceived as a threat to public health. A white paper on HIV and tuberculosis published by the AIDS Action Council raises issues of major concern. The vulnerability of the HIV-infected population requires changes in clinical management, including changes in diagnostic and treatment regimes for active TB, especially MTR-TB. The seriousness of the HIV-TB link cannot be overstated. However, TB is a broader problem than HIV and must be addressed as such. Our organizations have a long history of cooperating with OSHA and CDC on the development of standards and guidelines to limit the transmission of infectious diseases. The TB guidelines published by the CDC in August 1991 call for stricter applications of long-standing infection control techniques and describe the need for new strategies. They also include recommendations for early identification of patients with infectious TB and screening and surveillance of patients and healthcare workers. However, without training to ensure that healthcare workers have up-to-date information, standards and guidelines have limited effectiveness. We support federal policies which would require annual education for all healthcare professionals to ensure that they are current on infection control diseases and procedures. We have continuously pushed for better compliance and enforcement of CDC and OSHA standards. Facilities must provide the protective equipment as necessary for the safety and health of the workplace. These agencies need more resources to ensure compliance and for research on new protections. These efforts must be coupled with research to develop personal protective equipment that is not cost prohibitive. Additionally, research is needed on responsive drugs to fight TB. The FDA must have the resources and policies to facilitate efficient development and approval of effective anti-TB drugs. We are encouraged that CDC is preparing an action plan on drug-resistant TB, which will be directed to providers and healthcare professionals. However, CDC has no enforcement or compliance authority. Their guidelines often become standards of practice. Experience has shown us that we want changes in education and practice measures for employers, that other agency must be charged with that responsibility. Nurses are a fundamental link in educating the public about disease prevention and health promotion. We have a history of providing educational programs. We have developed educational models for public and professional use. Our organizations will continue to work with federal agencies to ensure development of effective policies and resolutions which encompass education, prevention, and treatment regarding tuberculosis. Additionally, we urge Congress and the federal and state agencies which have jurisdiction over research in public health and safety issues to work together. These agencies must have appropriate funding to ensure adequate qualified staff and leadership in ensuring enforcement and compliance of relevant existing regulations. This is especially important in education and training regarding hazards, equipment and engineering control use, and reporting of adverse incidents. Certainly, agency action is also critical for product effectiveness, safety, and cost evaluation. We urge Congress to provide an emergency supplemental appropriation to address this serious public health problem and substantially increase TB funding for fiscal year 1993. We need to ensure the health and safety of the American people through sound public policy and commitment of resources. Thank you, and may I request my full statement be submitted for the record.
Without objection, that will be done. Your entire statement will be entered into the record. And I thank all of the panelists for your testimony, and we will use the 5-minute rule as we start off. Some of the statements in your testimony have been repetitive, but I really think that we have to make it clear, so you'll bear with us if we ask questions which seem to be perhaps redundant. Dr. Bloom, Was this epidemic preventable?
Yes, this epidemic was preventable, and I think perhaps the best evidence I can provide is that in the very poorest countries of the world, as I mentioned, Tanzania, Mozambique, Nicaragua, there are something on the order of 85% cure rates in those countries, and the drug resistance is on the order of 10%. We can't even give you a number for the cure rates in New York City. We don't know that number, but from some hospitals it's less than 20%. And clearly drug resistance is 1/3 of all the isolates. So we're not doing as well as even the poorest of developing countries. Yes, it could have been prevented, and it can be headed off now.
One of the most frightening aspects of the TB epidemic is multiple drug-resistant tuberculosis. What are the mortality rates for this form of the disease?
If you don't treat ordinary tuberculosis, about 50% of the people everywhere in the world have died. If you have multiply drug tuberculosis, the numbers are small, but Dr. Eisman at the National Jewish finds that also, no matter what you do, whatever drugs you give, 50% die. It's the same as having a drug that you can't treat at all. In AIDS patients, of course, that figure is very much higher. It's closer to 80 or 85%.
As an immunologist who has worked on vaccines, what is your estimate of how long it will take to develop an effective TB vaccine for persons at greatest risk of infection?
I'll break it into two answers. The CDC has declined to recommend that the existing vaccine, BCG, be used for two reasons. One is we don't really know how good it is. In some places it's 80% protective. In other parts of the world it's 0% protective. And we haven't had enough research to understand why. The second reason was we don't really know whether BCG will be safe in HIV-positive individuals. It's never been used in that context before. What I can say is within a year, we would hope from our lab and perhaps others to have strains that we think are safe even if people have no immunity and won't kill anybody. It will be a longer time to develop a better vaccine, many years indeed, than the one we have now.
Dr. El-Sadr, do you think a greater federal effort is needed in TB control?
Absolutely. I think the problem of tuberculosis is widespread and does affect and will affect everybody. There needs to be a concerted federal effort at all levels to advance the areas that I feel will be effective in controlling the epidemic, advancing the knowledge, providing the treatment in the manner that we know can work, and in developing widespread prevention and treatment programs. It cannot be done on a local, small-size programs. It has to be federal funds through federally funded programs directed to areas with the highest incidence.
Have there been cases of drug-resistant TB among the staff of Harlem Hospital?
Unfortunately, yes. I think that is the dreaded fear that a lot of healthcare workers today have, especially in, I think, New York City and maybe other urban communities. As Dr. Bloom mentioned, the treatment of such cases is quite difficult, the mortality is quite high, and our ability to cure these patients is quite limited. I think having these cases does highlight the importance of investing the funds rapidly to understand the multi-drug resistant organism and, importantly, how to prevent the transmission from the patient to the providers.
Dr. Stark, but what are the implications of the rise in multiple drug-resistant tuberculosis for children?
Well, fortunately, we have not seen very many cases yet of multiple drug-resistant TB in children, but clearly that's coming. Many of the drugs that are available for use in adults to treat multiple drug-resistant tuberculosis are not available for use in children. They are contraindicated because of other side effects or, in some cases, lack of knowledge. So when it does come into the pediatric population, it will be even more difficult to treat than it is in adults. Also, we have no idea how to prevent the development of tuberculous disease in children who are infected with these multiply resistant strains. We have no idea whether there are any drugs that work at all.
BCG vaccine is used in some other countries to prevent TB in children. Should this vaccine be used in children at high risk for TB in the United States?
As Dr. Bloom mentioned, the BCG has many problems in terms of our lack of knowledge, but if there is one population, most experts agree BCG has some effectiveness, it's children. None of us are advocating widespread use of BCG vaccine, but many of us who work with children with TB are coming in contact more and more instances where we are considering using the vaccine. Children who are going to inevitably be in exposure to multiple drug-resistant cases. In my own practice, I am using BCG with some increasing frequency.
Ms. Russell, you were trained and worked at Jackson Memorial Hospital in Miami, weren't you?
Yes, sir.
Would you tell us briefly how that hospital handled their outbreak of drug-resistant TB, which affected at least 65 persons, and estimate the cost, if you will?
Admirably is the best word I can think of. And it shows that intervention can bring things under control because they have responded once it was identified. They have addressed the air handling systems. As I mentioned in my testimony, it's key to be able to, first of all, assess people early on, identify them, and put them in the proper kind of air handling room, not isolated, but segregated away from other populations of people, and then be able to intervene with the healthcare worker wearing appropriate masks, et cetera. So they have seen a turnaround. You know, I'm not have all the figures at my fingertips or privy to me, but I know from talking at my colleagues there, because they have developed just a tuberculosis department, they've put a lot of emphasis on it and have brought it under control. It's not gone away, it won't go away, but they are bringing it under control and have instituted mechanisms that need to be done more widely in other places.
Thank you. Mr. Thomas?
Thank you very much, Mr. Chairman, and thank you all for your testimony. This is an area in which most of us are not knowledgeable, and you certainly help. Dr. Bloom, I think you said there was a cure rate of about 11% compared to something quite higher other places. Is this because we don't know what to do or aren't doing what we know how to do?
We know what to do, and I don't want to minimize the problem, and perhaps Dr. El-Sadr, who actually deals with that problem. Problem is the lack of compliance. Patients come, they're feeling terrible, you give them the drugs, in a month they feel better, and they stop taking their pills. And the problem is they will relapse at a very high rate. And perhaps I will turn it over, if I may, to Wafa, who will be more helpful.
I think to a large extent we know what the right thing to do. However, as I mentioned in my testimony, it requires tremendous resources to be able to do what is needed to completely treat and cure a patient with tuberculosis.
You mentioned, for instance, Nicaragua. Now, I can't imagine that they have more resources to do this job than we do.
I think what they have is they've been able to, in a lot of these places, to provide the directly observed treatment, the ability to go out in the community and make sure the patients are receiving their treatment. That is a very, that requires significant funds, actually. It requires that you have outreach programs, requires you have transportation, requires that you have someone who is willing to find the patients, trace them, bring them back. All of these are things that I think partially explain the difficulties we've had in getting a better track record.
What it is sort of a conundrum, isn't it? I mean, surely we spend much more on research, we spend much more per capita on health care, and yet you cite other countries as having a better result. That's curious. And I think, Dr. Stark, you mentioned a very high incidence of foreign-born testing negative as opposed to domestic. Isn't that a contradiction with what we're hearing here?
Well, across the United States, about 22% of all cases occur in people who were born in foreign countries and then have moved to the United States. And that is a significant minority of the number of cases. I think we need to emphasize that means that 78% of the cases occur in people who were born and raised in the United States. In children, even though the rates are much higher in foreign-born children, the rates in U.S.-born children in the surveys I noted were still astronomically higher than had been recorded 20 years ago.
You know, we always need more resources, but give me some notion. It's my understanding that CDC's, the budget request is up $34 million, and which is 110% over last year, will be $66 million. What kinds of figures are do you have figures in mind?
I don't have figures that I can invent, but I can say that we have 4,000 active cases in control in New York City, and the Department of Health figured that what one needs is about 400 people whose job it is to make sure everybody is either cases are detected early, or supervised in their treatment. And their figure was something on the order of a request of about $40 million for New York City, one city, which is more than the whole CDC budget. Now, what I can tell you we have at the moment is 7 healthcare workers who are assigned to directly observe therapy. So it's just unrealistic to believe that you can get 4,000 people, of which a high percent are non-compliant, to take their drugs and not be infectious and not develop resistance with only 7 DOT healthcare workers dedicated.
Let me ask you, Ms. Russell, or anyone for that matter, but the very practical problem. I've had, just this week, people in my office advocating for more spending on cancer research, more spending on Alzheimer's, more spending on AIDS. We have to make these decisions. There's not an endless amount of money. How would you take it away from some of the others?
That's your job. No, I know, it's a very difficult question. I understand what you're saying. But I think one of the little differences is that this is one of the very few diseases that's out there that is airborne, and that under the right conditions, you can put the general public at risk to. I don't mean to make that sound like it's that easy, but yet at the same time, we do know, unlike with many cancers, we don't know how to intervene and stop the spread. That we know what to do, we just need the money to allow us to go out and do it. And to pick up on my remarks before, I mentioned Jackson has been able to implement things to control it within the hospital, but not within the community, because it's still a major problem. That's why it will not go away. They will continue to come in the hospital. Once they come in the hospital, they're identified to provide protection there. But these people are released to the streets. You know, their address is under the 95 bridge, and there's no mechanism to really truly follow up and make sure they complete their treatment and that they don't spread it to other people on the streets.
I agree with that completely, and one thing that separates this is this is a public health disease, and one of the obligations of government is to protect the public health. Second, this is a fixable disease. The 4 of us are asking you to put us out of business, and we have no doubt that we have the tools available, and soon we'll have even more, for us to be out of business. Just to give you an example of how well these measures work, in Houston, Texas, we took a bunch of adult patients whose compliance with treatment was only 20%. And by giving them what we call directly observed therapy, and by a small incentive program where we would actually give patients small incentives to be available for treatment, we took compliance in that number of patients up to 90%. Now, yes, it's labor intensive, but at the cost of one drug-resistant case being $250,000, costly doesn't mean it's not cost-effective. We're talking about cost-effective preventive measures.
Thank you. I believe my time has expired.
Thank you, Mr. Chairman, and thank you very much for your testimony. I can't tell you how many chest x-rays and tuberculin tests that I had growing up. The tuberculin test was always interesting when that little puff on your arm grew up and came under the skin. In any case, Dr. Bloom, when you talked about that we're not treating conventional tuberculosis, the cure, if you will, and I guess it was Dr. El-Sadr who said that it was a lengthy process. In my dad's case, he was in the sanitarium for a year, which was complete bed rest, and the air quality. He was often put out into the cold with others to deal with clean air efforts, but he was there for a year. Is the treatment now, and I'm talking in terms of conventional tuberculosis, the same? Do we need that length of time to cure patients? Do we need going somewhere for 6 months, 3 months, 2 months? Is there a larger population of people now than we had earlier on, in which we could have someone go to a sanitarium, go to a hospital, spend as I say in my father's case, a year's time at that time to be cured of tuberculosis. What is now the length of time in being able to deal with a cure? Under what kinds of circumstances can we treat the disease? And I'm talking about conventional now, where I'm presuming that we're looking at the same kinds of, if these are the same kinds of treatments for conventional tuberculosis.
I think it's an important question. The available drugs that we've had, and perhaps the reason for the complacence, are very effective. And studies have been done, and I would point out much of what we've learned about treatment was not learned by research in the United States. It was learned by drug trials in countries, in foreign countries, in South India, for example, and in Hong Kong, where the numbers are so high one could get really very good statistical data. And it was shown that you could use good drugs, 3 good drugs, and drop the time from 1 year to 6 months and have greater than 95% essentially long-term cures. Okay, so that meant people could work. Could be ambulatory treatment instead of hospital beds for a year. People could have time with their families. They ceased to be infectious after 1 to 2 months. It revolutionized the treatment of tuberculosis to make it a thing that was not life disruptive, perhaps almost too easy. So 6 months is the recommended treatment, and now if there is any risk of resistance, they recommend 4 drugs, but 3 in the ordinary circumstance should be sufficient.
Should we go back to a system that talks about a sanitarium where people can go and be treated? And
I'll talk about a simple system. Do you know that there is not a single clinic in New York City that's open after 5 o'clock? So if you have someone who needs 4 months of maintenance treatment that wants to have a job, does not want to be unemployed, that person has nowhere to go to get supervised or unsupervised treatment from a city clinic. I mean, there's some very simple things that don't cost a lot of money that would make treatment available.
Dr. Stark, what would be the cost of providing a tuberculin test for youngsters in city clinics, public health agencies? I mean, is that a direction that would make sense in terms of youngsters, the increasing number of youngsters?
Well, the cost of the materials are very, very low. It's something like 60 cents per unit for testing, and clearly the majority of cost is in labor, is in people. Even though I am a pediatrician and I advocate for children, I am not as strong an advocate of mass screening of children for tuberculosis as people might expect. Children get TB from adults. They don't get it from other children. And the way to wipe out childhood TB is to wipe out adult tuberculosis. In this era of limited resources, screening of children is not the most important activity. Rendering adults non-infectious and cured and doing contact investigations of those adults is. So until we are able to fully do that in communities, New York City being a good example where that's just not being done, screening of children will have to be done eventually if we're really going to eliminate this disease, but it's not the major thing we need to do right now.
Well, how do you deal with children in a household with as I say, a set of circumstances that I was in? I mean, I did not, throughout my dad's life, he would not let me drink from a cup or a glass that he had used or use a fork or knife that he had used. I mean, he was that preoccupied with the question of infection. Is that, I mean, what are we talking about with children who are in harm's way, if you will?
Well, fortunately, 2 things. Fortunately, the medicines that cure tuberculosis are also very effective at preventing it. If the people who are infected, that is with positive skin tests, are identified before they become ill, we can put them on medicine so they never get sick, assuming they have drug-susceptible TB. So health departments concentrate their activities on going after children who live in households or families where there are cases of TB. Second, although it is becoming more difficult to do, we can prioritize children by their risk of TB. We know who the children at highest risk are. One of the problems is getting at those folks. You know, the average family that I see in my clinic also has to go to WIC clinics and Medicaid clinics and many, many other places, and working the system is extraordinarily difficult. And for them, their child coming to my clinic and getting TB treatment truly may not be the most important thing to them, although I may feel it is the most important thing. Mm-hmm. And that's the problem, is all the other services that many patients require.
Mm-hmm. Thank you, Mr. Chairman. Thank you.
Thank you, Mr. Luro. Sometimes, you know, we get so caught up in using the language of the particular discipline that we sort of go over the heads of people. And so what I'd like to do is to have you, for example, we've used the term directly observed therapy. And it gets into this whole question area of why can the Nicaraguans, for example, do this and why we can't. Describe what directly observable therapy is, so it's not just a phrase that we throw about.
Yeah, if I may, because 75% of my kids with TB are on directly observed therapy. Directly observed therapy means that a healthcare representative, healthcare worker, directly observes the administration of the medication to the patient. And it can be done either in the clinic setting, which requires the patient to come to you, or it can be done in the home setting, or the school setting, or the work setting. One thing about tuberculosis is, especially beyond the first month of therapy, we usually only have to give people medicine 2 times a week. That is, assuming it's drug-susceptible TB, but just twice a week to effect a cure, which means we can go to their house twice a week. Now, one of the problems is recruiting other people to do this for us. Who is going to do this? For instance, in my city, school nurses are not allowed to give medications to children. So even though we have kids in school with TB who are not contagious, it still requires a healthcare worker or someone going out to give the medication. The opposite, of course, is self-administered medication, which we know from all studies ever done that at least 30 to 50% of patients, irrespective of socioeconomic status, education, gender, race, color, creed, etc., 30 to 50% will not take medications. This is another place where TB is different. If you have hypertension and you don't take your medicine, that's bad, and you may develop a stroke or a heart attack. But if you have TB and you don't take your medicine, not only might you relapse, but you will relapse with drug-resistant tuberculosis, which you can then pass on to other people. That's what makes TB almost unique among public health diseases requiring long-term and, I think, directly observed therapy.
Right. And so at the outset, I think you just said before, it's labor-intensive. It takes a lot of people to do this. If you do it, in fact, the costs ultimately are diminished or eliminated because, in fact, the disease goes away. You've cured it. And there are a lot of diseases where you can't say that for. And so, again, it seems to me that this is clearly one of those situations where a stitch in time saves 9, where if you do it and you spend the money up front and you do it aggressively with a well laid out comprehensive plan of doing it, then it seems to me that the costs, which may seem prohibitive at the beginning, in fact are not, because you can put it back in the pages of the history books. You can eliminate it and then keep your eye on it to make sure that it doesn't recur again. And that really, in a sense, is what the focus of these hearings are, is to see why and how we've allowed it to sort of escape us, to slip through the cracks, and to have a plague which had been, for all practical purposes, eliminated, has managed to come back. I too am of an age where a friend of mine was, a schoolboy friend of mine, was sent to a sanitarium. And now we don't have the sanitarium. We don't have, as you say, we don't have the clinics to send them to for the most part. And it is, I think, a process of re-education and focus, and not being penny wise and pound foolish, that we really understand that we're not really saving money by cutting back and not making the expenditures in this area when it's timely and makes sense to do it. You have anything further to say?
I would just add, Mr. Chairman, to what you've said, and that so often as we sit here at hearings, and we often ask up here, well, if you could give us some guidance, because the resources are not unlimited, as to what would you pick out? Which direction would you go in? And in this case, it's been so terribly clear that you've all have said that we know how to solve this problem. We know, and there are often times where there just aren't clear cut answers. There are, and particularly in the health area, there are various areas in which we haven't plumbed the knowledge we yet need to know about the direction. Here we're talking about understandable ways in which we can address what is a very serious issue and an area which we know how to solve or begin to take the steps to solve it. And I think we would do an enormous disservice to the health of this country if we just sat by and did nothing about it and not go back where we do need some additional information in the drug-resistant strain and look at the clinical trials, deal with this issue again, because that's a new direction we have to go in. We have some very set patterns of what we can do now. We just need minimal resources to get ourselves back on track and to put this back in the pages of history. Thank you very, very much for coming forward this morning. Thank you, Mr. Chairman.
Thank you, Mr. Lauro. And Mr. Thomas, I think, made a telling point in his opening statement that although you're all, in a sense, big city representatives, that half the caseload has come from the rural areas, that it is not just a big city problem. It has hit all of America. And that, all of America needs to be concerned because we're all subject to this contagion. Again, thank you all very, very much for participating in this hearing and for the important work that you've been doing, and wish you good luck in your efforts in the future. Thanks. Our next panel is comprised of experts from within the federal government, and if Dr. Roper, Dr. Fauci, and Ms. Pendergast will take their positions behind their nameplates so that we can swear you all in. Would you stand and raise your right hands? Do you swear or affirm that the testimony that you're about to give will be the truth, the whole truth, and nothing but the truth?
I do.
Thank you very much. Let the record indicate that each of the witnesses has responded in the affirmative. And Dr. Roper, I think we'll begin with your testimony.
Thank you, Mr. Chairman. It's a pleasure for me to be here today, especially with my colleagues from the Public Health Service, to talk with you about a very important problem. CDC is the nation's prevention agency, and one of the most important issues we are dealing with today is the problem of tuberculosis in the United States. The hearing you are having today is very timely, and I especially commend the previous panel for their clear and compelling explanation of this problem and its solution. Treatment of active tuberculosis disease normally requires 6 to 9 months of daily or twice weekly therapy with 2 or more drugs. But as you've heard, unfortunately, if patients with active TB fail to take medication as prescribed, or if the regimen prescribed is inadequate, drug resistance can develop. Drug-resistant organisms are transmissible to other persons. This collection of issues, that is the long duration of therapy, the need for continued adherence to what may be a complicated regimen, and the possibility of resistance to some drugs, makes the challenge of tuberculosis control very great. We as a nation first began uniform national TB reporting about 40 years ago, and over that period of time there's been a steady decline in active tuberculosis cases from 84,000 in 1953 to 22,000 in the mid-1980s. But our surveillance system began to show us in the middle 1980s that long decline in tuberculosis cases had leveled off. And from 1985 to 88, the national trend became essentially level. Our counts for the past year, 1991, show an increase now to 26,000 cases, a 2.3% increase over the number for 1990. It's important to note, however, that tuberculosis continues to decline even today in 28 of our states. Therefore, by 1991, the number of TB cases reported annually had not just leveled off, but has begun to increase by 18% over the last 5 or 6 years. In New York City, which you've just heard about in detail, they saw a 182% increase in cases over the decade of the 80s. CDC data show that by race and ethnicity, the largest increases in TB cases recently have occurred among Hispanics, a 55% increase, blacks a 27% increase, and Asians a 20% increase. We believe the increases in Hispanics and blacks are dominantly due to the HIV epidemic, which similarly disproportionately affects these minority populations. As others have explained to you, a positive skin test for tuberculosis means a latent infection, but only a fraction of those with this latent infection go on to develop the clinical illness we call active tuberculosis. A study done in New York a few years ago showed that the risk of clinically active tuberculosis developing in people who are HIV positive and who have had a positive skin test is 7% per year. That's several times higher than the risk in persons who have positive TB skin tests but who are HIV negative. Another important issue is what portion of tuberculosis patients are infected with HIV. We've done a number of surveys across the country and have shown that this percentage varies widely from a low of 1.4% in one metropolitan area to 46% in New York City. That is, 46% of TB patients in New York are infected with HIV. The most recent cause for alarm with respect to tuberculosis, as you've heard, is the occurrence of outbreaks of multi-drug resistant TB. Of the 17 outbreaks or clusters of drug-resistant TB cases reported over the last 15 years, 13 of those 17 have occurred in the last 2 years. So far, these outbreaks have occurred primarily among persons with HIV infection, but there have been instances in these recent outbreaks of extensive transmission of infection to caregivers. The likelihood of further transmission to the general community is now a major concern. CDC must be prepared to provide immediate and adequate response to investigate and contain these outbreaks wherever they occur. As I will elaborate later, we've developed, in concert with our colleagues in Florida, a model for such action, and that was quite successful in Miami, as you've just heard. We must also improve surveillance of the problem and improve laboratory capabilities promptly to detect new cases. I'd like briefly now to go over what CDC is doing to address the TB problem. In 1991, we created a federal task force on tuberculosis with representatives from NIH, FDA, the Health Resources and Services Administration, the Indian Health Service, the Alcohol, Drug Abuse, Mental Health Administration, the Occupational Safety and Health Administration, and the Federal Bureau of Prisons. This group is developing a national action plan to combat multi-drug resistant tuberculosis, and that plan should be available in the next few weeks. We've worked closely with state and local health departments, especially in Miami and New York State and City, to devise strategies to control multi-drug resistant tuberculosis. We held a meeting in January on the challenge of multi-drug resistant TB, a national meeting attended by 350 persons, and the deliberations from that meeting have gone into this action plan that I've noted. CDC administers the nation's TB grant program to prevent, control, and eliminate tuberculosis, And in addition to the basic grants to states and territories, this year we're also funding several demonstrations of screening and preventive therapy in high-risk populations. We're also funding several projects to determine the efficacy of various preventive treatment regimens among persons who are infected both with tuberculosis and HIV. And other projects have been funded to assess the efficacy of current TB drugs in treating HIV-infected TB patients. Since 1990, CDC has been involved in efforts to prevent and control outbreaks of drug-resistant tuberculosis. Especially, we have put our resources into New York City and Miami, where there have been hospital outbreaks.
Dr. Roper, I think that the time allotted for the statement has expired, but we'll have plenty of time during the question period.
May I take one more minute and summarize quickly, sir? I would go on to note the other activities underway recently, a series of training courses that we have undertaken with our colleagues in state and local health departments, guidelines that we've developed to deal with the special problems of HIV in healthcare and correctional institutions, and working with our colleagues in the FDA to make available drugs as the U.S. manufacturers are gearing up to deal with the problem. Finally, the President's budget for next year, which is pending before the Congress, has a 110% increase in funding for tuberculosis. All of this goes together, I believe, to make the point that we need continued vigilance to control public health problems, even when we think they are waning. We need to invest in technology and infrastructure to control future outbreaks of tuberculosis and, again, other public health problems. That's why my highest priority at CDC is strengthening the nation's public health system. Thank you. I'd be happy to respond to your questions.
Thank you, Dr. Roper. Dr. Fauci?
Thank you, Mr. Chairman, members of the subcommittee. It's a pleasure for me to appear before you today to testify about ongoing planned tuberculosis research activities at the National Institute of Allergy and Infectious Diseases and at the NIH. The problem of tuberculosis, as you've heard today, has been unfortunately compounded by years of decline in basic and clinical research on TB. One of the reasons for this decline is that many scientists and clinicians perceive tuberculosis as a problem that had been solved with the advent of antibiotics. The resultant attenuation of the tuberculosis research community has left us with the task of rebuilding this establishment. The pharmaceutical industry will also need to be encouraged to get involved in this problem, since during these years they reduced their effort to develop new or improved therapies. As a consequence, with the exception of certain newer techniques which are not yet widely available, we're still fighting tuberculosis with diagnostic techniques developed a long time ago, without new antibiotic therapies and without an effective vaccine to prevent the disease. During the last decade, the NIAID has sought to strengthen significantly its tuberculosis research effort. Support for TB research has risen from approximately $500,000 in 1979 to $3.5 million in 1991. The original fiscal year 1992 budget for TB research is approximately $5.2 million, which represents approximately 48% increase over the 1991 level. In addition, and in response to the research needs identified at recent meetings, we've established two new TB initiatives for fiscal 92. In October 1991, NIAID released a request for proposals for the purification of tuberculosis research materials. These resources will enable investigators who are interested in doing research on MTB to move rapidly into this area. The second NIAID initiative addresses the need to stimulate research to develop new drugs for the treatment of TB. Nearly 2 decades have passed since the introduction of a new drug for the treatment of TB. Beyond these major initiatives, NIAID is supporting TB-related basic research projects in areas such as the isolation of protective and diagnostic antigens and TB chemotherapy. Some progress has been made in developing new drugs. We are supporting grantees who are working in the preclinical development of implantable formulations of isoniazid and other anti-TB drugs. In the area of clinical trials, we are supporting research on TB as an opportunistic infection associated with HIV. Currently, 3 protocols are active within the Terry Barron Community Program for Clinical Research on AIDS, one of which is being conducted jointly with the AIDS Clinical Trial Group. In addition, we're funding a study through the Pan American World Health Organization to evaluate the efficacy of chemoprophylaxis for TB in HIV-infected TB skin test positive persons in Mexico. In the field of epidemiology, we're supporting an investigation of the impact of TB infection on the natural history of HIV infection. As I mentioned above, in the fiscal 1992, our estimated support for TB research is $5.2 million, an increase of approximately 48% over 91. This increase reflects our commitment to respond to the urgency of the TB problem as it was recognized by the research community in late 1990 and early 1991. By late 1991, amid reports of a significant increase in the incidence of multiple drug-resistant TB, it became clear that additional strategies were required. Recognizing that the rise in the number of multiple drug-resistant TB infections would necessitate an even more aggressive TB research effort, the NIAID convened a workshop of experts in the field of TB in February of 1992. The goal was to help us develop a research agenda for the prevention, diagnosis, and treatment of TB. As a first step in responding to these research recommendations, I have taken immediate action to increase the NIAID TB research efforts in fiscal 92. After conferring with division directors and staff and after meeting with the director of NIH, we feel confident that the resources can be found to fund this accelerated effort. In this regard, Dr. Healy, the NIH director, testified last month before the House Appropriations Subcommittee for Labor, Health, and Human Services that she is considering the use of her transfer authority to help fund the NIAID TB research effort in fiscal 92. In addition, although our budget request for 1993 was developed more than 1 year before the acceleration of our TB effort, we are now in the process of discussing with Dr. Healy what possibilities exist within the NIH 1993 budget to enhance our TB research initiatives beyond what was originally planned. To extend our TB research efforts in 92, I outlined for you in my written testimony a variety of specific projects in basic research, diagnostic, epidemiology, drug development, and clinical trials. In conclusion, we're firmly committed to supporting the scientific research that will be an essential component of a successful strategy to stem the tide of re-emerging TB. Through coordinated efforts at the NIH, with the CDC, the FDA, and other agencies of the Public Health Service and the World Health Organization, we hope that TB can finally be relegated to a disease of the past. This concludes my oral statement, Mr. Chairman. I'll be pleased to answer any questions.
Thank you very much, Dr. Fauci. Mr. Prendergast, I understand that Dr. Goldberger is with you and has been sworn. Right. You're just going to respond to questions. Is that the idea?
Correct.
Right. Okay. May I suggest to people in the audience that the protocol of these hearings is that the dialogue is between the witnesses and the members of Congress, and I think that that's the most effective way of carrying through on what in fact have been mandated upon us as the rules of the House. Dr. Roper, let's look first at CDC's grants to the states for TB elimination. What you requested and what you got in the President's budget request over several years. According to your records, you requested $5 million, and in the President's budget, you got $4 million in 1988. In 1989, you realized that there was a TB problem and asked for $25 million, and you got $7 million from the President. In 1990, you requested $29 million, and you got $7 million from the President. In 1991, you asked for $34 million, and you got $8 million from the President. In 1992, you asked for $35 million, and you got $12 million in the President's request. Now, what should we think of this? Were those real public health needs or just pie in the sky? Why didn't you fight for that money? Did you think you could eliminate TB in the United States with a half or a third of the funds that you requested? Obviously, the answer has to be no, and today we have an alarming TB epidemic.
I didn't hear the last part of your statement, sir.
Well, the answer to the question is why? Well, the question was, why didn't you fight for the money that you yourself requested, rather than having it seriously cut back in the president's proposal in the budget from what you had requested in the first instance? It wasn't because you believed, I assume, that it wasn't because you believed that you could eliminate TB in the U.S. with a half or a third of the funds that you requested. How did that happen?
Sure. In the middle 1980s, the level of tuberculosis had leveled off in this country, and the experts, my colleagues and predecessors at CDC, were convinced that it was an opportune time to mount a major additional effort fully to eliminate tuberculosis in the United States. That's the plan that was put forward in early '89, and that's what led to this major increase in requested funds from the Centers for Disease Control through the department and so on.
But I heard no outcry when you asked for $25 million in '89 and got $7 million in the president's budget request. And I don't want to go through the numbers again. 90, you asked for $29 million, you got $7 million. So that by the time you recognized it and you requested the funding for it, and it wasn't coming, what kind of reaction was there really at the presidential level? Didn't they believe what you and your people were suggesting to them and submitting to them and requesting of them?
The requests in '89, '90, that period, were requests to mount an additional effort to eliminate a problem that we thought was on the wane in this country.
Right, but then you weren't getting it. Yeah.
May I finish my answer? The problem that we began noticing late in 1990 and surely in 1991 was that tuberculosis was increasing significantly, especially multi-drug resistant tuberculosis. And so the tenor of our requests changed from, we need this money to go ahead and eliminate fully a long-standing, indeed ancient problem, changed to, we have a major series of outbreaks of a problem that is not going away, indeed is increasing, and that has led to our getting the resources. The year, you noted the years up through '92. In the request for '93, we initially requested $17 million, and the President's budget reflects an amount of $35 million. That, I think, is indicative of the fact that the nature of the TB problem has changed, and whereas we've gone from an activity that competed with a lot of others that were important, worthy activities, to being an emergency that merits special attention now.
But in 1993, you asked for only $17 million.
We initially did, but as the year progressed and our understanding of the problem increased, we increased that request.
The previous year, in 1992, you had asked for $35 million. And so really the question is, had in your mind the problem improved sufficiently for you to ask for half the amount that you had asked for previously, or had the policy makers above you and beyond you decided to override your requests, and you felt that well, that's the way it was going to have to be? I just don't understand the up and downs of the requests that were being made, and the amounts that were being then requested by the President.
A general point I'd make in response, Mr. Chairman, is continuing to deal with ongoing public health problems is a challenge that we face, whether in the executive branch or the legislative branch. When we are successful with prevention, nothing happens and news is not made. And so it requires the best of our talents to convince others to fund activities that are dealing with problems that are on the wane. The lesson...
But the fact is, you know, that Congress consistently appropriated greater monies than what the President had requested. Year after year after year, you would make a modest request, the President would cut it back, and the Congress would then make a higher appropriation. So it's not as if everybody were into this bag of not providing or not recognizing the problem. For whatever reason, the executive branch, policymakers, numbers people, if you will, had not as urgent a sense of the problem as you did or as Congress did. And the question again is, what were you in a position to make a public appeal and a public objection, if you will, to what was happening to the tuberculosis epidemic, and why the numbers that you came up with, that you had requested to begin with, were not the numbers that you picked out of the air, but that these were absolutely minimal to being able to do the job that needed to be done.
My predecessor as director of CDC put forward a plan, a strategic plan to eliminate tuberculosis in early 1989, and that became the basis for a wide-scale effort to mobilize the nation against tuberculosis. We've made progress. Now, however, we need to make much more progress because of the multi-drug resistant problem.
When was the first substantial outbreak? When was the first substantial outbreak of multi-drug resistant tuberculosis reported to CDC?
The first one was in 1990.
And were other outbreaks of drug-resistant TB reported in 1990 or 91?
Yes, sir, especially in 91.
And a CDC document states, indeed, that 12 outbreaks of multiple drug-resistant TB were reported to CDC in 1990 and 91, including Florida, New York, Mississippi, Missouri, and Michigan. Didn't these signal a significant increase in drug-resistant tuberculosis?
Sure they did.
So it would be fair to say that you had knowledge of both the swelling TB caseloads as well as the multiple drug-resistant TB outbreaks well before the fiscal year 1993 budget request was presented to the Public Health Service.
Yes.
Okay. Well, I'm going to yield at this point to Mr. Laura.
Thank you, Chairman. I'd just like to pursue the budget question for a moment, Dr. Roper. I guess the President requested a total of $66 million for TB activities in fiscal 93. That's the total amount. And yet the Urban Caucus, which I'm a member of, and the Chairman is a member of, along with the Congressman Payne and Shays, who sit on this committee, they recommended increasing that amount to about $100 million. What's your view? Do you feel that $66 million is enough?
I think it's going to take more than that to deal quickly with the problem. Mm-hmm. We are at the present time looking carefully at what our judgment is, given the changing nature of the epidemic, and I don't have a firm number for you right now.
Mm-hmm. And let me just ask you to follow up. The Chairman is saying, what are you prepared to do to see that number goes up?
I'm prepared to do what I did to get the fiscal 93 President's budget number up, which is push very hard, first within our department and then OMB and the White House, to acquaint people there with the problem as they are now acquainted, so that the dollars will flow as they have.
So can we approach you on the Urban Caucus's
sure.
Recommendation and talk that through to see if we can increase?
About that.
Let me just, I talked to some of the health officials in my own state of Connecticut about this, about our efforts in Connecticut to control a TB. And one of the things that they talked to me about was the need for some technical assistance on management information systems. And I just wanted to ask you if you have the resources for helping local officials use their computer technology to track the TB cases, to manage treatment. Do you have that kind of, can you provide that kind of help? If you do, are there plans to make this kind of help available to localities? And in your view, what do we need to do to provide technical expertise to local health officials?
Very good question. We have already developed a new laboratory software system, a system to enable laboratories to use computers to keep track of their laboratory activities and the patient testing results, and that has already been transferred to all of the state health departments. We're currently developing a similar software system modeled on the one that we developed several years ago to keep track of AIDS cases, to enable the states to have a similar epidemiologic capability to keep track of their tuberculosis patients.
When will that be available, Dr. Roper?
In a few weeks.
A few weeks, okay.
Yes. In addition to the development of those kinds of resources, we have federal officials from my agency who are assigned either temporarily or permanently to assist tuberculosis control programs in the states and localities. For example, currently we have 5 employees assigned to the city and state of New York. I don't have the number for Connecticut right now, but we are increasing the numbers of those employees that we deploy for giving on-site assistance to both clinical and management challenges.
Do you have enough personnel to deal with the situation now, Dr. Roper?
No, we're hiring more right now because of the additional resources that we now have.
And that's because of the increase in the number of cases, the increasing proportion of incidence of the disease that you...
Yes, ma'am. It's a challenge that we are carefully working on with our colleagues, again, in state and local health departments. Practically everything we do at CDC is done in partnership with them.
Okay. Tell me, is there any work that's being done to find ways to help to protect some of the healthcare workers that we heard about in the prior testimony? Healthcare workers, prison guards, in terms of prevention of and the spread.
We have, within the last couple of years, published new guidelines for both correctional facilities and healthcare facilities on how to prevent the transmission of tuberculosis in those settings. In addition, both our National Institute for Occupational Safety and Health and our National Center for Infectious Disease are working on new techniques to minimize the risk of transmission in those settings. They range from modification of the airflow in those facilities to wearing masks, the use of ultraviolet lights, which can kill the tuberculosis bacterium, a variety of other things that will minimize the risk to healthcare workers and correctional facility workers.
Now, on that issue, is that the responsibility of the locality to take care of making sure that those kinds of precautions are taken, that any costs resulting from the implementation of these guidelines is a cost that localities pick up?
If you're asking me, do we have federal monies for the construction costs or bricks and mortar costs for these facilities? No, our grants don't pay for that. Those are local expenditure, state expenditure.
Well, even in terms of the implementation of some of the guidelines, if there's any kinds of cost measures that are involved with any of this, then that becomes the jurisdiction of the locality.
Our grants can help them with the implementation of these new activities, but just not the bricks and mortar part of it.
Have you had any, I'm sorry, Mr. Chairman, I'm going over the time, I'll finish this up.
Yes, ma'am.
Have you had any word back from the localities saying that they can't afford to do some of these things, that they're unable to implement some of these things because of a lack of funds.
Yes, that's a problem because the building of new prisons, the building of new hospitals, even without tuberculosis, is a major fiscal problem for all levels of government. What we're talking about is going to add to that cost, and yes, people have said they've got a problem.
Okay. Thank you very much. Thank you, Mr. Chairman.
Right, Mr. Lauro. Again, let me admonish members of the audience that it is in violation of our rules to have a dialogue, oral or written, other than that which we're engaging in with the witnesses. Dr. Roper, I understand that CDC is considering shifting $15 million from HIV prevention to tuberculosis control. What is the status of that reprogramming request?
We've gotten full agreement within the administration to do that, and the paperwork is being prepared to request such a reprogramming from the Congress, and that should be to Capitol Hill by next week.
Do you plan to shift funds from HIV to TB in fiscal year 1993?
We plan to use more of our HIV dollars directly related to tuberculosis, but we are doing it in a way that doesn't diminish the effort in other parts of the HIV prevention activity.
How many staff positions, FTEs, are there currently in the Division of Tuberculosis Control?
There are 55 in Atlanta at our headquarters and 35 at other locations around the country. As I mentioned, there are 5 of them in New York City right now.
Now, how many were transferred from the Division of HIV Prevention?
We've had some. I don't have that number, but I'd be happy to supply it for the record.
I would think that it makes little sense to raid the HIV prevention program to get funds and staff for tuberculosis control.
I'd answer you in 2 parts, sir. Given the very close link between HIV and tuberculosis, what we're achieving is not a rating of HIV, but rather a synergy between these 2 programs that will serve them better. And as to the dollars, we, again, are not diminishing the level of effort in HIV prevention. We are using a technique given by changing the funding cycle of some of our grants to free up dollars this year that can be extended further next year. But nobody, no program, no activity is going to receive less dollars this year because of our freeing up these dollars for tuberculosis.
Well, in these budget tables, funds from the HIV prevention program are included as TB and HIV. Now, are these funds counted in the HIV prevention budget as well? Are they counted twice?
They are counted as part of our effort against HIV and our effort against tuberculosis because they are used simultaneously, for example, in HIV clinics to test people who are infected with HIV to see whether they have tuberculosis, and in tuberculosis clinics to test those people to see whether they are infected with HIV.
But don't they give an exaggerated picture then as to the numbers of people?
No,
who
sir,
are involved?
they give a clear picture of the way we're using these funds to get the synergy I mentioned earlier.
How many persons in how many states in the United States currently have drug-resistant TB?
We don't know because we do not have in place yet a national surveillance system for drug-resistant tuberculosis.
Well, there have been reports of TB, drug-resistant TB, of about 200 persons, roughly, in 13 states, and there may be others.
Yes, sir, those are the reports that we've got to date.
Right, well, so you said you do have some numbers. Drug susceptibility testing has not been done routinely and takes weeks to perform, I understand. Is that right?
That's correct, though we and our colleagues in the other agencies are working on new techniques to speed up the process of testing for drug susceptibility, as well as speeding up the identification of tuberculosis at the beginning.
How many hospitals have reported drug-resistant TB?
I believe 8, but I'll be happy to supply that for the record.
Yeah, our information is that 6 hospitals have done so.
It may well be.
I understand that you have a schedule conflict which makes your schedule of such as to leave at, you have to leave by 12:30, but I would appreciate it if you would stay with us while we ask some questions of Dr.
Sure,
Fauci
please
until
do.
that time. Dr. Fauci, in about April of 1991, when your FY93 budget request was presented to the NIH director, either you knew about the TB epidemic or you did not. What would be the answer to that?
We were aware of the trend in TB increasing that had gradually been coming up from the mid-'80s. We were not, nor was the biomedical research community aware of the seriousness of multiple drug-resistant TB at that time. Certainly there were cases and reportings of multiple drug-resistant TB that were around, but they've been around for a considerable period of time. The actual outbreaks that call to the attention of the biomedical research community, we were not fully aware at the time that we made the 1993 budget up.
Did CDC inform you of the TB epidemic, or did you read about it in the papers?
I wasn't personally informed. We read about it in not only the papers, but in the MMWRs that came out, as well as in our discussions in our interdepartmental
And
meetings.
when would you say that occurred? When you read about it first?
A real appreciation of the impact of multiple drug-resistant TB did not come until the end of the summer, in the fall of 1991. Not from the standpoint of a public health containment, but from the standpoint of a biomedical research approach towards something that looked like it was going to be a problem that needed to have accelerated basic research. I'm speaking purely from a fundamental research, basic and clinical research standpoint, not from a public health standpoint.
I do have a list of 18 MMWR articles from the period from July 1985 to March 1991, demonstrating that there were plenty of indications of a TB epidemic long before May of 1991, right, when your budget was presented to the Public Health Service.
That is true, Mr. Chairman, but you have to look at it from the standpoint of whether that signals a modification or an acceleration of basic biomedical research for which my institute is responsible, or whether you're looking at outbreaks that are related to the immunosuppressed state of an HIV-infected individual, poor compliance with treatment regimens that you've heard about so far this morning. Certainly, we were aware of that, but that is somewhat different from having a whole new ball game of the emergence, the significant emergence of a multiple drug-resistant epidemic. So from a standpoint of an awareness that TB was increasing during the period of time where you're referring to the MMWR, certainly we were aware of that. But from the standpoint of the need to make an accelerated biomedical research effort vis-a-vis multiple drug-resistant TB, that did not come until after the 1993 budget was made up. And I might add that we have, since that time, as I'm sure we'll get into, responded by accelerating our effort both in 1992 and in planned for 1993.
The President's fiscal 93 budget request for NIAID contains $5.4 million for tuberculosis research, only $200,000 more than the fiscal year 92 appropriation. Is that correct?
Approximately that.
Now, what was NIAID's original request for fiscal 1993?
When we make a request for a budget, we don't have a line item for tuberculosis. It's within the realm of the budget that we make judgments as to what we're going to be spending on TB. And an example of that was that in 1991 to 1992, for example, we increased our effort by approximately 50%. So it's within the area of the budget to make the decisions, as we have made, to accelerate our effort in 1992, as well as a planned acceleration in 1993.
Well, according to your budget office, NIAID's original request for fiscal year 1993 was $7.8 million. Would you disagree with that?
And we were going to be spending considerably more than $7.8 million in 1993. We plan to do that.
Do you believe that either amount, either the $7.8 million or the $5.4 million, is adequate to conduct the necessary TB research given the type of epidemic that's facing the nation?
Certainly the epidemic is serious, and as I have just alluded to a moment ago, we are planning to spend considerably more than that. It's within the discretion of our budget to accelerate or decelerate areas as the emergency or lack of emergency would dictate. At the time that the budget was made out and submitted for 1993, as I mentioned just a few moments ago, really no one in the biomedical research community was aware, certainly aware of a problem from a public health standpoint, but what we can do about it from a biomedical research standpoint and whether it was appropriate to move in an accelerated fashion was somewhat problematic at the time. What we have done in our plans for an accelerated effort within our budget is that in 1992, which started off with a $5.167 million budget, we are going to increase that by adding a planned redirection of monies from the Small Business Innovation Research PIs, as well as I mentioned in my statement, I have had discussions with Dr. Bernadine Healy, the director of NIH, who is right now seriously considered, and I think it will happen, a increase of $4.25 million from her 1% transfer authority to give us a total in 1992 of $9.9 million. That will be carried over in 1993. So the effort that we are mounting within the budget for 1993 as it now stands reflects an awareness of an acceleration of our effort.
Well, you were recently quoted in Newsday as saying that, quote, even with an infusion of funds, it will be years before we can answer such basic questions about TB as, quote, when is a person contagious, close quote. Do you still believe that to be true?
As you've heard from Dr. Bloom, the problems at the research level will in fact take years. I don't think that we're going to have adequate drugs in the next couple of weeks. We're not going to have a vaccine this year. We need greater diagnostics. All of that takes time, as well as rekindling the interest of investigators throughout the country to get involved in research. As I mentioned in my statement, we had an attenuation of researchers because investigators did not perceive this to be an important or a necessarily interesting problem. We're seeing that change right now, and hopefully with the acceleration of our effort in 1992 and 1993, we will see an infusion of new investigators into the field. All of that is going to take some time. You're not going to turn the research effort around overnight, but we are accelerating our effort to make that come to pass as quickly as possible.
How long will it be before there are better, shorter acting drugs?
Well, right now we're in the process of taking a look from the standpoint of our national cooperative drug discovery groups, which we established for HIV infection and the opportunistic infections, and we plan to supplement these groups to enable investigators to include tuberculosis in their studies. We cannot predict how long it will take to get another new and effective drug for TB that might help in the treatment of multiple drug resistance, because that's research, and research is discovery. You can never predict, but we hope that this will be much sooner rather than later as the interest gets rekindled.
How long will it be before there are diagnostics that can tell physicians whether a TB patient is drug resistant, and if so, to which drugs?
Again, right now, in work both at the NIH as well as at the CDC are currently working on that problem. There are molecular techniques that are in the process of being developed, some of which are already being used. They're at that stage where they're not widely available for clinical diagnostic use, but I would hope that this would rapidly evolve into a more readily available techniques because of the inadequacy of the current techniques that you've heard about this morning. We really can't predict how long that will take.
Should doctors rely on the skin test for diagnosing tuberculosis?
Particularly in an HIV-infected individual who's immunosuppressed because of the HIV, it is very problematic to rely on a delayed cutaneous hypersensitivity reaction in the skin. That has been one of the problems when you're dealing with an immunosuppressed patient, and it is the reason why we need better diagnostics.
Patients as well as healthcare workers are becoming infected with drug-resistant TB. What research are you conducting on treatments to prevent the active disease from developing?
We have a number of protocols which we've initiated, particularly in our community program for clinical research on AIDS, since most of the problem, a vast majority of the problem that we're seeing is in the HIV-infected individuals, and we're looking at evaluation, the safety and the efficacy of isoniazid in a 6-month course in the prevention of clinical TB in anergic, namely people who don't have a positive skin test, HIV-infected persons who are at high risk for tuberculosis infection. We're also planning a healthcare worker study within our community program to document the incidence of PPD conversions among healthcare workers so that we can get a better handle on the kinetics of the problem of transmissibility from an HIV-infected, TB-positive patient to his or her healthcare worker.
But will these prevent drug-resistant TB?
Well, drug-resistant TB, as you've heard earlier this morning from the other panel, is enhanced by inadequate treatment. You can have multiple drug-resistant TB in a person who has never been treated for tuberculosis, but it is much more likely, and the induction of multiple drug-resistant TB occurs certainly significantly greater in an individual who has not complied appropriately with their therapeutic regimen. You've heard Dr. Bloom and others allude to that, where a person might come in requiring a regimen of consistent therapy for 6, 9 months, or even a year, and takes therapy for a month or so, feels better, and then decides not to continue taking the drug. That's a perfect setup for the induction of multiple drug-resistant tuberculosis.
How much do you think that you'll need for research for fiscal year 92? How much additional?
We have called together a group of experts in February of 1993 to help us to set a research agenda. Dr. Bloom, the previous witness, was a prominent member of that group.
92, you mean, then? February of 92?
I'm sorry, February of 92. Right. I'm sorry, Mr. Chairman. Right. It was during that time that we put together an agenda to try and plan out feasible research that could be done already now in 1992 as well as projected for 1993. It was on the basis of that that I began immediately moving money beginning in 1992, such as the SBIR that I mentioned and the request for a transfer
think that you'll need for research for fiscal year 92? How much additional?
We have called together a group of experts in February of 1993 to help us to set a research agenda. Dr. Bloom, the previous witness, was a prominent member of that group.
92, you mean, then? February of 92?
I'm sorry, February of 92. Right. I'm sorry, Mr. Chairman.
Right.
It was during that time that we put together an agenda to try and plan out feasible research that could be done already now in 1992 as well as projected for 1993. It was on the basis of that that I began immediately moving money beginning in 1992, such as the SBIR that I mentioned and the request for a transfer from Dr. Healy of approximately $4.25 million. That will be carried over into 1993, and we are exploring every option within the NIH budget to be able to implement most, if not all, of the recommendations of the working group that we called together in February.
And how much can you spend in fiscal year 93?
How much will we spend?
Yeah, can you spend in
That's a dynamic process, Mr. Chairman, because as I mentioned, we are planning to both redirect money, and we are in the process of negotiating with the director of NIH for getting money within the NIH budget to not only carry over from the 1992 transfer, but also to have monies moved to be able to implement the recommendations of the committee.
Well, you've been quoted as saying that you could spend an additional $38 million in fiscal year 93 on TB research.
Yeah. Within that are the carryovers from the acceleration that took place in 1992. We can do a considerable amount with that, and we plan to put into motion projects over and above that within the realm of approximately 33 or so additional dollars, and we feel that we're going to be able to, within the NIH budget, certainly explore all possible mechanisms, not only within our own budget for redirection, but also, as I mentioned, the NIH director has been very helpful in exercising her transfer authority to give us the funds within the NIH budget.
Dr. Roper and Dr. Fauci both, to what extent does the research being conducted by CDC overlap with that of NIAID?
We have very close collaboration with Dr. Fauci and his colleagues at the NIAID. If you mean by overlap, create a money-wasting problem, there's no overlap. I would be pleased to give you examples, though, of the collaborative efforts that are underway where we're working together successfully to develop principally diagnostic tools, but other treatment and other modalities. That we have a very close relationship.
Ms. Prendergast, several TB. Yeah.
In the task force that Dr. Roper has alluded to, in the development of a coordinated plan, we have a number of subcommittees, and one of those subcommittees is the research subcommittee, which has members from the CDC and the NIH and other agencies, and one of the major rationales of that subcommittee is not only to coordinate research, but also to ensure that we have complementary, not overlap.
Ms. Prendergast, several TB drugs are no longer being produced in the United States. We need all these drugs for the treatment of drug-resistant TB. What is the situation with regard to streptomycin and PAS?
Chairman Weiss, we agree with you that you can't treat TB without drugs, and the treatment of TB is essential for the eradication of the disease. When the FDA first learned that two drugs, streptomycin and PAS, were no longer available in the United States because the sole manufacturer of each of those two drugs had decided to go out of production, we took an active leadership role in trying to get these drugs back onto the market. Basically, we have a two-stage approach. Our first effort is to get a long-term, steady supply of these drugs. We've worked with the pharmaceutical community, and we've asked them to bring these old drugs back onto the market. Several companies have responded to our request, and I can tell you now that Pfizer and another company have agreed to produce streptomycin. They will be filing marketing applications sometime this summer, and they will go into full-scale production by fall. And also, Dr. Jacobus of Jacobus Pharmaceuticals has agreed to produce PAS. He too will be filing a marketing application this summer, and we hope, if all goes well, he'll get marketing approval by this fall. But we can't wait till next fall. And we felt we needed a mechanism to get drugs to the American public now. Consequently, we engaged in quite literally a worldwide search for companies that met U.S. standards that would be able to come and fill the gap. Fortunately, we found companies that were willing to do it. Glaxo of Canada has graciously agreed, with financial support from its American subsidiary, to provide free streptomycin to American patients until the American producers can get up and running. Similarly, ICN of Canada has agreed to provide PAS to the American market until Jacobus Pharmaceuticals can get up and running. We then turned to the CDC and asked for their help. We needed a mechanism, someone to hold what's called an investigational new drug exemption, to hold that exemption and distribute the drug to the American public. CDC has agreed to do that, and in the next 2 weeks, all should be in place and the drugs should be back on the market and available to patients.
I've heard that there's a shortage of INH, but I have a letter from the major manufacturer, Barr Laboratories, that says they have 30 million pills available. Why the holdup? Is there evidence that they are contaminated?
First of all, Congressman Weiss, there is no shortage of INH. A couple of months ago, we thought that there were going to be difficulties with INH. However, we do have stable, steady supplies of that drug from 3 different pharmaceutical companies. With respect to Barr, then, from a public health perspective, the Barr tablets are not critically important because we do have drug from other companies, good quality drug. The Barr tablets were produced not in accordance with their approved marketing application. They didn't meet the standards or the specifications that they were supposed to meet. The FDA is also somewhat concerned about the quality of the product. We are working hard with that company in the hopes that it will be able to overcome its difficulties and get back into production and get its drug distributed to the American public. But until it overcomes the legal problems it's having, the quality problems it's having, those drugs have to remain on hold. I think that the Barr story raises an important point. We're willing to scour the earth to find manufacturers for these drugs. We're willing to work with companies to overcome their problems, and we are willing to expedite the review of applications and to expedite our inspections of these companies. The one thing we cannot do is lower our standards for safety and efficacy.
What are you doing to prevent shortages of other desperately needed TB drugs?
What we learned from streptomycin and PAS is that we needed an early alert system so that we would know as soon as the companies made a corporate decision regarding their drugs. Consequently, what we've established is that alert system. We've done an inventory of all the companies that make either the bulk chemicals or the finished dosage form drugs. We have contact points in each of those companies, and we have asked them to notify us if they have any intentions to scale back or cease production. We are also working with the Pharmaceutical Manufacturers Association, and they too have asked all their member firms to tell us and the Centers for Disease Control if they intend to cease production. We are doing periodic surveys and in the hopes of finding out information. But I think the most important thing, and it's something that this hearing is doing, is that we are trying to engage in an education effort. When the corporations that made PAS and streptomycin quit production, I don't think they appreciated the fact that TB was not being eliminated, but rather was on the rise. Through educational efforts such as this hearing, we are teaching the American pharmaceutical industry that it's critically important for them to stay in this market, and hopefully no other companies will make decisions to leave the market.
Thank you very much, Mr. Prendergast. I want to thank each of you separately and as a group for participating in these hearings. I know that in retrospect, you will agree with me that there has in fact been a failure to be as sensitive to the development and resurgence, if you will, of this epidemic as there was. And again, and something that we've spoken about at hearings of ours over the years, very frequently it's the policymakers, if you will, who are making, and the numbers makers who make the judgments above and beyond your posts as to how a particular area fits into the budget situation, rather than looking at the information that the scientific people have documented as the genuine needs are in order to protect the public health. And this is a perfect illustration of how, if you rely on people who don't really have a scientific involvement to make the decisions for you, they will think that all that they're doing is scratching out numbers and reducing budget lines. In fact, what they're doing is causing an alarming increase in an acceleration rate of an epidemic, a plague, if you will, which for all practical purposes had been wiped out in this country. And that, of course, strictly from a budgetary point of view, ends up costing much more in dollars and cents than had the initial commitments been made to provide the required amounts that the scientists said were needed. This is the second of these hearings that we've held on tuberculosis. The one that we held in New York a couple of months back, we had testimony that going back to 1980, 1981, we had people who were working in the field and who were issuing reports and highlighting the growth of this epidemic. And yet, even though there were reports coming back to all of you and to people above you, nobody seemed to want to pay attention to what was going on. And you know, the people who paid for it in the first instance were the most vulnerable in our society. But ultimately, because of the nature of this disease, everybody is subject to it. Everybody becomes vulnerable. And you don't just have the poor and the homeless and the drug addicts, but you have the healthcare workers and the hospital workers and the doctors. And pretty soon, if you don't attend to it, you have the general populace at risk. And I just urge you to keep your eye on what's happening, because our role, yours and mine, is in fact to try to make sure that which Congress had intended in mandating you to protect and mandating us to protect the public health is done. It is not sufficient after the fact to say, gee, we really should have known better. The lesson, I guess, from all of this is we're still at a position where we can make a terrible situation, we can prevent it from becoming a truly great tragedy in this country. And I hope that, in fact, that issue will be addressed by you and will be addressed in sufficient resources, with sufficient resources, so that the American people can take hope in the commitment to protect their health and well-being. I thank you all very, very much and urge you to continue to do the good work that is essential in order for your responsibilities and ours to be fulfilled. Thank you very much. The subcommittee now stands adjourned, subject to the call of the chair. Thank you very much. I appreciate you standing by.
For more information on these proceedings, write to the House Government Operations Subcommittee on Human Resources and Intergovernmental Relations in room B372, Rayburn House Office Building, Washington, D.C. 20515. You'll be able to see this hearing again in its entirety tomorrow night beginning at 9:50 Eastern Time, 6:50 p.m. Pacific Time, right here on C-SPAN 2. Coming up in just a few moments, it's Democratic Congressman Dan Rostenkowski of Illinois on health care. Good day from Washington, D.C. You're watching C-SPAN 2. Our non-profit cable satellite public affairs networks are brought to you as a public service by the national cable television industry and your local cable system. We're pausing now to update our programming, and first we have a reminder to be with us Sunday for Road to the White House, our weekly look at the 1992 presidential campaign. He will attend a rally in New York City with former California Governor Jerry Brown and sit in on a media forum with Mr. Brown and members of New York's Latino community. You will also see a conversation on how to run an independent presidential campaign with former independent presidential candidate John Anderson. He ran back in 1980. That's all on Road to the White House Sunday beginning at 6:30 p.m. Eastern Time, 3:30 p.m. Pacific Time on C-SPAN 2. Now turning to our Saturday afternoon programming. Coming next, it's a speech to the American Group Practice Association by Democratic Congressman Dan Rostenkowski of Illinois, discussing health care reform. After that, at 1:35 p.m. Eastern Time, 10:35 a.m. Pacific Time, it's a health care forum sponsored by the San Francisco-based think tank called Pacific Research Institute for Public Policy. You will see Nobel laureate economist Milton Friedman along with Canadian economist Michael Walker They will discuss health care reform here in the United States. We will follow that forum with a speech to the Canadian Club of Toronto by Republican U.S. Senator Frank Murkowski of Alaska discussing environmental issues. Finally, at 4:15 p.m. Eastern Time, 1:15 p.m. for our West Coast viewers, it's a hearing of the Joint Economic Committee taking a look at U.S. Latin American economies and the proposed North American Free Trade Agreement. And that's a brief look at our Saturday afternoon programming on C-SPAN 2. Cable television can be an effective teaching tool. That's especially true for the programming on C-SPAN, so we created C-SPAN in the Classroom to help educators teach with C-SPAN. Members receive educational resources free of charge. If you're a teacher who wants more information, write us at C-SPAN in the Classroom, 400 North Capitol Street, Suite 650, Washington, D.C. Our zip code is 20001. Approximately 200 executives from the nation's leading medical group practices met in Washington, D.C. this week to discuss the potential impact of legislative health care reform on patient services. On Thursday, 17-term Democratic Congressman Dan Rostenkowski of Illinois, who is chairman of the House Ways and Means Committee, spoke about his proposals for health care reform. Chairman Rostenkowski is the sponsor of a bill that would establish Medicare rates for all health care services.
Okay. Could you take your seat?